Hello, my name is Junko Takeshita. I am an assistant professor of dermatology and epidemiology at the Perelman School of Medicine at the University of Pennsylvania. And I want to thank the National Psoriasis Foundation for inviting me to speak to you about health disparities, an old problem in new times. This is my disclosure. And here are the objectives for this presentation. By the end of this talk, I hope you will feel comfortable defining health and healthcare disparities, explaining the causes of health disparities, and describing some general approaches to eliminating health disparities. Much of what I'm presenting is not going to be psoriatic disease specific, but are important general concepts to understand with regards to disparities, and that I want to encourage all of us to think about in our own journey towards studying and addressing health disparities in psoriatic diseases. So I want to first start by defining health disparities. We've been hearing a lot about health disparities and using the term disparity in the last year. And in some instances, it's used correctly, and in others not. And it is so critical that we understand exactly what health disparities are so that we can properly identify and ultimately eliminate them. The first definition I present to you comes from the National Institutes of Health. And the NIH defines a health disparity as a difference in the incidence, prevalence, mortality, and burden of disease and other adverse health conditions that exist among specific population groups, and they specify within the United States. And I too will be specifically talking about disparities in the United States in the time that we have today, but this is certainly not a US specific issue. Now, the NIH is certainly a trusted source of information, and this definition may be sufficient to many of you, or maybe some of you feel like something is missing. So let me present another definition to you that comes from the Healthy People Initiative, which is an initiative designed to guide national health promotion and disease prevention efforts to improve the health of our nation. And according to Healthy People, a health disparity is a particular type of health difference that is closely linked with social, economic, and/or environmental disadvantage. And the key point here is linking a health difference to some sort of disadvantage, which is absolutely essential in defining a health disparity. Therefore, unlike what the NIH definition suggests, not all health differences are health disparities. Lastly, I want to present a definition from Margaret Whitehead, a prominent figure in the health equity field, especially in the United Kingdom. And she defines a health disparity as a difference in health that is avoidable, unjust, and unfair. Now, this is my favorite definition because it is short, it's easy to remember, and includes all the key components of what a health disparity is. Now, today I'm specifically going to talk about racial and ethnic disparities, but please know that there are many different types of disparities that are also critically important to understand and address. So why do we care about health disparities? Beyond the ideals of equity and the belief that each person has a right to have access to the necessary resources to achieve their maximum health, health disparities are expensive. For example, the excess direct medical care costs due to racial and ethnic health disparities alone in the United States was nearly $230 billion based on an old estimate from 2003 to 2006. And these costs have not decreased over time. Another reason that we need to address racial and ethnic health disparities in particular is that our nation is projected to become increasingly diverse. So much so that we are expected to become a majority minority nation by 2060, as you can see in the bar graph on the right. Non-Hispanic white individuals are anticipated to make up only 44% of the total population, as indicated by the gray bar, again on the right. Therefore, left unaddressed, racial and ethnic health disparities can only be expected to worsen. So addressing health disparities must be a priority. And this has certainly been recognized on a national level via multiple avenues, some of which I've listed here. First, in the latest iteration of the Healthy People Initiative, which is Healthy People 2030, one of the overarching goals is to eliminate health disparities, achieve health equity, and attain health literacy to improve the health and well-being of all. Second, the Patient-Centered Outcomes Research Institute, which is an independent, nonprofit, non-governmental organization authorized by the Patient Protection and Affordable Care Act of 2010, identifies addressing health disparities as one of its 5 national priorities for research. And third, the National Institutes of Health is committed to eliminating health disparities, not only via the National Institute of Minority Health and Health Disparities, but also via NIH-wide initiatives to support research to address health disparities, advance health disparities research, and also to eliminate structural racism in biomedical research. And of course, the National Psoriasis Foundation's own priorities are in alignment with these, and the NPF is committed to addressing health disparities related to psoriatic diseases. Now that we've covered some definitions and the importance of addressing health disparities, I next want to talk about how we think about the causes of health disparities, using COVID-19 as an example. In part because this has been such a large part of our more recent lives, and also because for many, their first introduction to health disparities has been through COVID-19. While health disparities have existed for a long time and are certainly not limited to COVID-19, the stark disparities in COVID-19 related outcomes that emerged rapidly and continue during this pandemic have forced our country to finally pay attention to health disparities and to make addressing them a real priority. This graph that was updated in March shows the continued racial and ethnic disparities in mortality rates due to COVID-19 across the country, where Pacific Islander, Latinx, Indigenous, and Black individuals are all more likely than white individuals to die from COVID-19. Now, in order for us to understand the causes of these and other health disparities, we need to also understand what major factors or determinants are that contribute to our health. As we can see in this figure, in most cases, genetics or biology are not the main factors that determine our overall health. Individual behaviors and social and environmental factors play major roles in determining our health. These social and environmental factors are also known as the social determinants of health. In other words, a more formal definition of this are the conditions in the environments in which people are born, live, learn, work, play, worship, and age that affect a person's health. And the social determinants of health are major causes of most health disparities. Now you can see here that healthcare also plays a role in determining a person's health, albeit a smaller role compared to the social determinants of health. And disparities in healthcare can result in health disparities. And I will define healthcare disparities in a little bit. Before we discuss the social determinants of health a bit more, I want to also briefly mention the historical practice of redlining, because this has important health implications even today. For those of you who are not familiar with redlining, this is something that began in the 1930s when the US Housing Act created the Federal Housing Association. And in turn, the Federal Housing Association established mortgage underwriting standards that discriminated against minority neighborhoods and steered prime mortgage investors away from minority areas in a process called redlining that literally delineated undesirable neighborhoods with red shading on maps, as you can see on the map on the left, which indicates redlining in Philadelphia. Now, while I'm showing you this specific example of Philadelphia, because this is where I live, you can find similar historical examples of redlining in many major cities. Now, these redline areas were deemed unfit for investment by banks and other financial services, and this was determined largely based on the racial and ethnic composition of mostly minority individuals in these neighborhoods. And ultimately, redlined areas were left undeveloped or in disrepair. Unfortunately, redlining has had long-lasting effects on health, including COVID-19, that we're still experiencing today. If we keep with our Philadelphia example, starting again with the redlining map on the left, where the red and yellow areas indicate the least desirable places to live, we see that this has some significant overlap with the areas in Philadelphia that remain highly segregated and where a higher percentage of Black individuals in particular live, as indicated by the darker shades on the map in the middle. Now, when we compare these maps to the map on the right, which shows the number of COVID-19 cases, with darker orange indicating a higher number of cases, we see also quite a bit of overlap with the more highly segregated areas, and again, many of which were historically redlined. Now let's add one more map to this. The green map in the middle indicates areas of something called structural susceptibility. And this is a measure of the structural characteristics of a neighborhood that are produced by systems of racism, in this example, redlining, that put people at risk for COVID-19. So this green map is a composite measure of things like risk of exposure and community transmission of COVID-19, for example, based on measurement of percent crowding in a neighborhood, percentage who are service workers or frontline workers, or percentage who use public transportation. Also measures of poor access to testing and treatment for COVID-19, for example, based on the percentage who are uninsured, or capture the potential for short-term and hardship from COVID-19, for example, percentage of people living in poverty. So the darker green areas indicate greater structural susceptibility. And as you can see, once again, there's quite a bit of overlap among many of the dark areas in each map, from the left to the right. And this is a prime example of structural racism and how it affects a person's health. And while again, how I'm showing you here a Philadelphia specific example, this example is applicable to many other cities across the United States. So if we put this all together, we have some explanations as to why Black, Hispanic, and other minority individuals are more affected by COVID-19. And the answer is not biology or genetics. To simplify things a bit, if we focus specifically on the Black-white disparity, we know Americans are more likely to have many of the risk factors for COVID-19. And this actually applies to many other racial ethnic minority groups as well. Beyond the social and environmental factors that contribute to the racial and ethnic differences in risk factor burden, there are also many social inequities that Black and other racial and ethnic minority Americans face due to structural racism that we just saw in the maps I showed you, that place them at higher risk of developing COVID-19 illness. So the most impacted minority groups are more likely to live, for example, in segregated neighborhoods and houses with more inhabitants that increase their exposure risk. Many minorities are also more likely to be frontline workers and rely on public transportation to get to and from work. And these are the social inequities that put them at higher risk for COVID-19. Fortunately, we now have some very effective vaccines against the coronavirus. However, we also see racial and ethnic disparities in vaccination rates, as shown in this graph, where Black and Hispanic individuals have lower vaccination rates than white individuals across the country. And again, effects of structural racism contribute to disparities in vaccination rates as well. If we look again at the maps of levels of segregation and structural susceptibility on the left and middle, respectively, and compare this to a map of vaccination rates on the right, again, we see significant overlap. Now, in this instance, we want to compare the light areas in the blue map, which indicate lower vaccination rates, to the darker areas in the gray and green maps. So the areas of lower vaccination rates in lighter blue overlap with the darker gray and green areas indicating greater segregation and structural susceptibility in the left and middle maps. Now, for psoriatic diseases, we haven't yet developed a good understanding of the social determinants of health or the social determinants of psoriatic disease outcomes, but I want you to keep these things in mind as I pose some questions for us to consider in a little bit. Now that we've reviewed what a health disparity is and what some of the causes are, I want to define healthcare disparities next. The Institute of Medicine defines a healthcare disparity as a difference in healthcare access and clinical interventions experienced by certain groups that are not due to clinical appropriateness or patient preferences. And again, the importance of healthcare disparities is that they result in health disparities. Now, just as not all health differences are health disparities, not care differences are healthcare disparities. Again, any healthcare difference that is due to clinical appropriateness, for example, differences in disease presentation or severity, or due to differences in patient preferences, is not considered a healthcare disparity. But anything to operations of healthcare systems and biases, stereotyping, and uncertainty, for example, in the clinical encounter and among healthcare providers, is considered a healthcare disparity. So what are the causes of racial and ethnic healthcare disparities? In 1999, the Institute of Medicine was tasked by Congress to answer this question. And their answer was in this report called Unequal Treatment, which summarized the state of health and healthcare disparities in the United States and how to address them. And I want to share one of their conclusions, which is that racial and ethnic minorities tend to receive a lower quality of healthcare than non-minorities, even when access-related factors such as patients' insurance status and income are controlled. And stereotyping, biases, and uncertainty on the part of the healthcare provider can all contribute to unequal treatment. While healthcare providers collectively represent just one component of the larger healthcare system, we cannot underestimate the importance of the patient and provider interaction that may contribute to healthcare disparities. So with that, let's finally move on to talk about psoriatic disease, and specifically psoriasis. There are some data that suggest potential racial and ethnic health disparities related to psoriasis. So let's start with a very basic question. How common is psoriasis, and does it similarly affect individuals of different races and ethnicities? United States population-based studies suggest that the prevalence of psoriasis in the United States differs by race and ethnicity, whereby psoriasis is most common among white individuals, as shown in this table. Now, with this data, I do want to caution that this prevalence estimate is based on individuals having received a diagnosis of psoriasis from a healthcare provider. So we're likely not counting people who have yet undiagnosed psoriasis. And this is really important to be aware of because some studies suggest that non-white individuals may be more likely to have undiagnosed psoriasis. So this may mean that these prevalence estimates for psoriasis may be an underestimate, especially among non-white individuals. Now, what about disease severity? There are a few studies that also suggest that Black individuals in particular may have more severe skin disease. And beyond disease severity, we also know that psoriasis has a huge impact on the quality of life of individuals living with this chronic disease. So is this quality of life burden experienced similarly among individuals of all races and ethnicities? To answer this question, in work that we have done evaluating North American patients enrolled in a psoriasis registry, we found that the quality of life burden, as measured by the Dermatology Life Quality Index, a commonly used 10-question survey that measures the quality of life impact of skin diseases, this quality of life burden of psoriasis differed by race and ethnicity, where Black, Asian, and Hispanic patients reported greater quality of life impact due to their psoriasis, as indicated by higher scores compared to white patients, as shown in the table on the left. To give you an idea of what these scores mean, DLQI scores range from 0, indicating no effect, to 30, indicating extremely large effect on a person's life due to their skin disease. These racial and ethnic differences in quality of life burden persisted when we did a statistical adjustment for any differences across the groups in socioeconomic status, psoriasis severity, comorbid diseases, and treatment, as shown in the graph on the right, where again, we see that Black, Asian, and Hispanic patients were more likely to report any impact on their quality of life due to psoriasis compared to white patients. So if we put this all together, in general, while white individuals may be more likely to have psoriasis, at least Black individuals may have more severe disease, and Black, Asian, and Hispanic individuals each report that their psoriasis has a greater negative impact on their quality of life compared to white individuals. The causes of these differences remain unclear. As such, we don't know yet if these differences, particularly the differences in disease severity and quality of life burden, represent disparities. Though I think that many of us hypothesize that there is at least some component of a health disparity here. These are just a few examples of the many questions about disparities that we have yet to fully answer and address for psoriatic diseases. But how do we address and ultimately eliminate health disparities. I believe we need data to guide our efforts and policies to address health disparities. And I present this framework for disparities research that has been proposed. This is a framework that I apply to my own work and is what I think we should apply to psoriatic diseases. And it involves 3 sequential steps. The first is to detect the disparity. We need to define the health disparity and the populations it affects and measure the extent of the disparity. Once a disparity is detected or identified, the next step is to understand why the disparity exists. What are the causes? And then finally, once we understand the causes, we then can develop policies or other interventions or methods of reducing, and I would say ultimately eliminating these disparities. While we don't have time to talk about this in great detail, specifically with regards to psoriatic disease, this will be a topic of discussion this fall at the National Psoriasis Foundation Research Symposium. And I hope you will join us to learn more about the work that my group and others are doing in this area and continue this important conversation. Lastly, I want to end by briefly mentioning some general approaches to eliminating health disparities. First and foremost, we must address the social determinants of health. And what you see here are some examples of how people are addressing the social determinants of health in order to reduce health disparities. For example, by providing transportation to individuals to get their COVID vaccine, by providing the means to move from high poverty to low poverty areas. And lastly, by restoring vacant and blighted land in neighborhoods, and these are actually photos in Philadelphia, all aimed at improving health. While I didn't talk a lot about this, we must also address bias, both implicit or unconscious, and explicit or conscious biases in healthcare. And the first step to addressing biases is recognizing that we all have biases. Discussions about bias and bias training are being increasingly incorporated into healthcare provider training and in continuing medical education for healthcare providers. And these and other efforts will help contribute to the practice and delivery of more culturally mindful healthcare, which is what we need to address healthcare disparities. Lastly, we need to make sure our physician workforce adequately reflects our patient population that is becoming increasingly diverse. Particularly relevant to psoriasis is shown here. The dermatology workforce, as indicated by the red line, is unfortunately one of the least diverse across medical specialties. However, I'm anticipating and optimistic that this will change, as there are many initiatives that are being led, for example, by the American Academy of Dermatology, the Skin of Color Society, and individual medical school and residency training programs, among others, to address this issue. While there's much more to be discussed, I hope that if you didn't already, you now have a better understanding of health and healthcare disparities. And in summary, health disparities are widespread and have been present for a very long time. In order to eliminate health disparities, we really need to focus on collecting information on and understanding the social determinants of health. And for psoriatic diseases, we really are at the tip of the iceberg in terms of what we know about health and healthcare disparities. And there's still a lot that we don't know and need to discover. And again, I hope you will join us at the upcoming NPF Research Symposium to continue this discussion as we strive to achieve equitable care for our patients with psoriatic diseases. Thank you for your attention, and I look forward to your questions in our discussion.